Спасибо большое. Good afternoon, colleagues. My name is Kovets Yuri. I'm a professor assistant from Traumatological and Orthopaedic department. I hope you are well fit. And you know that afternoon lectures, it is a serious challenge not only for students but for teachers as well. But anyway, today we will start the course in orthopedics, and the first lecture will be degenerative disc disease. Colleagues, can you hear me? Can you write me something? Because I want to be sure that you can hear me. I need some feedback from you. Hello? Okay. Okay, so as usually, we will start from the basic, we will start from anatomy. Because if you don't know the basic principles, basic points, it will be very difficult to understand more complicated things like pathogenesis, clinical picture, and treatment. So as you remember, our vertebral column consists from few parts like cervical, thoracic, lumbar, sacrum, and coccyx. For each part we have minor anatomical structures which we call vertebrae, and general anatomical structures are quite similar. For each and every vertebra, almost for each vertebra, we have so-called body, then we have spinous process, then we have one pair of transverse processes, we have arc of the vertebra, and we have foramen. The foramens of the vertebrae form so-called vertebral canal. In that canal we have spinal cord and we have spinal nerves, which are very important. And as you know, the spinal cord is a part of the central nervous system. In between the vertebrae bodies, we have so-called intervertebral disc. The central part of the disc, which you can see right here, we call nucleus pulposus, and the peripheral part, which is located around nucleus pulposus, we call annulus fibrosus. Colleagues, if you will have some questions during the lectures, feel free to write the questions in the chat, and I will try to answer for your questions. Okay? In general, our today's topic, degenerative disc disease, will be discussion of the intervertebral disc pathology, because initial changes during that disease we will have exactly at the area of intervertebral disc. Okay, on that slide you can see ligaments, main ligaments of the spine. Right here you can see anterior longitudinal ligament, which is located on the anterior surfaces of the bodies. Right behind here we should have posterior longitudinal ligament, but it is absent on the picture. But the principle is the same. That ligament covers the posterior surfaces and split the intervertebral disc from the vertebral canal. Then in between the spinous processes, right here, we have so-called ligamentum intraspinatum. Then in between the transverse processes here and here as well, on the both sides, we have ligamentum intertransversum. Then in between the arcs of the vertebrae, let me show you. Right here, in between the arcs, we have ligamentum flavum or yellow ligament, and actually that is the most elastic ligament in our body. And all ligaments together provide the stability of the vertebrae and prevent so-called instability. So in norm, the displacement in between two vertebrae shouldn't be more than 4 millimeters. And angular displacement in between two bodies shouldn't be more than 10 degrees. If it's more than 10 degrees or if it's more than 4 millimeters, we call that condition instability. If we'll talk about the blood supply, it is perfect. For vertebrae in general, for spinal cord, for vertebral column, we have perfect blood supply. We have branches, if we'll talk about the arterial blood supply, we have direct branches from the aorta. Usually for lumbar part, it's around 8 to 12 branches which are supply the vertebral bodies, spinal cord, ligaments, and for the intervertebral disc we have small branches which are supply only the end plates of the vertebrae. The nutrition of the nucleus pulposus in general provided by diffusion. Spine motion segment, what is it? Each pair of the vertebrae, for example, C1, C2, C4, C5, L1, L2, form so-called spine motion segments. That means that all types of the movement, which are visible for the spine in general, can be seen in between each pair of the vertebrae. It can be rotation, it can be flexion, it can be extension, lateral bending, everything possible because of unique connection in between each pair of the vertebrae. So what is it, that unique type of connection? At the posterior part of the vertebrae we have so-called facet joint. It is a classic joint where we have articulating surfaces which are covered by the cartilage. At the anterior part, in between the bodies, we have that intervertebral disc. The central part of the disc, nucleus pulposus, is responsible for shock absorption. The peripheral part, annulus fibrosus, in general provide stability of the vertebrae. So together with the ligaments, which we discussed before, that annulus fibrosus stabilize the vertebrae together. Plus, annulus fibrosus hold the nucleus pulposus exactly at the center of the body, so prevent any displacement of the nucleus pulposus. So what is a degenerative disc disease? It is polyetiological condition or polyetiological disease which is result of destruction or decreased production of the mucopolysaccharides, chondroitin sulfate, glucosaminoglycans, and as a result it's lead to reduced concentration of the water inside the disc. If we will talk about etiology, first, as you can see on that slide, it is wrong postures, improper position during the work, during the rest, which can lead to the overloading of the spine. It is one of the reasons. Overloading during the physical exercises, overloading during some physiological processes, pregnancy, for example, it can be the reason of that disease development as well. Different types of traumas. As you can see here, it can be fractures of the spine, especially compression fractures. It can be some minor stress traumas. We call it stress traumas, the stress fractures. So it is a fracture which is happened in result of multiple minor loading to the same part of the bone, to the same area of the spine. Then it can be different congenital disorders. Most common is dysplasia or connective tissue dysplasia. So it is abnormal genetically provided type of pathology when the collagen and elastic fibers are not developed properly. Here you can see example with the hip joint dysplasia, when the acetabulum becomes shallow, and as a result the head of the femur become dislocated. It can be some kind of hypermobility of the joint, or it can be some kind of abnormal muscle stretching and different other types. And of course, aging. Aging, it is a reason why we have reduced production of the collagen fibers, elastic fibers, and in general reduced production of the hyaluronic acid, which is the part of very important part of the connective tissue. Actually, it is one of the reasons of the wrinkles formation, one of the reasons of the cartilage degeneration, and intervertebral disc degeneration as well. So if you talk about the pathogenesis, you will see that hyaluronic acid, it is a structure which is combined chondroitin and keratan sulfate, and without proper development of the hyaluronic acid inside the tissue, we will have reduced concentration of the water in that tissue, because chondroitin and glucosamine can attach the water, can keep the water inside the tissue, and less concentration of the sulfate, chondroitin sulfate, will lead to decreasing of the water concentrations there. Okay, so stages of degenerative disc disease. On that slide you can see different stages. The first one, it is initial stage of initial disc degeneration. So as you can see, during that stage we will have only narrowing of the space in between the vertebral bodies. That narrowing is the result of loosening of the water. As I said before, reduced production of the chondroitin sulfate and glycosaminoglycans will lead to decreasing of water concentration. So if you try to understand what will happen with the patient during that stage, you will see that most of the patients doesn't have any clinical symptoms. They doesn't have any pain, they doesn't have any neurological disturbances. So usually patients will not come to a doctor during initial stage. Another very important thing, you should understand that not everyone, not every patient pass through each and every stage. For most of the people, first stage, it is the last stage. So intervertebral disc degeneration not lead to other future complications like bulging formation or hernia formation. For most of the people, narrowing of the disc, that's all what will happen with the spine. But for some group of the patient, not very big, actually around some 3 to 5%, we will have formation of the bulging. So it is a condition when the nucleus pulposus, which should be located right here at the center of the body, start to displace somewhere. It can be displacement to the front, it can be displacement to the back, but anyway, nucleus pulposus will not stay at the proper position. And during bulging stage or protrusion stage, we will see first initial clinical symptoms like local pain. Pain which will be located exactly at the area where the bulging is formed. If it's a lumbar part of the spine, the patient will suffer from the low back pain. If it's a cervical part, then cervicalgia. If it's a thoracic part, then it will be thoracalgia. So local pain. Why patient will feel that local pain? Let me show you. Right here, you can see so-called Luschka nerve or sinovertebral nerve. It's located right here. So it is a branch. It is a branch from the spinal nerve, which is innervate the anterior longitudinal ligament, posterior longitudinal ligament, fibrotic part of the disc, and actually yellow ligament as well. So soft tissue inside the vertebral canal. And any irritation of that soft tissue will lead to Luschka nerve irritation, and as a result will lead to local pain. In our case, let's return to our picture. In case of bulging formation, that bulge disc will overstretch posterior longitudinal ligament. And that ligament overstretching we will feel as local pain. That will lead to the local pain syndrome. Next possible stage, it is a stage of hernia. It is a condition when the annulus fibrosus become ruptured and nucleus pulposus will came out inside the vertebral canal, and as a result, that material, disc material, can compress the spinal nerve or spinal cord. So together with the local pain, patient will start to feel irradiating pain. If it's a lumbar part of the spine, pain will irradiate to the leg. If it's a cervical part, the pain will irradiate to the hand. And we call it sciatica. So sciatica, irradiating pain, it is the first symptom of the intervertebral disc hernia. So now we come to the patient examination. So what is the plan if we examine the patient with the degenerative disc disease? As usually, I recommend you to use same principles, same plan for any patient examination. It doesn't matter is it orthopedic patient or it is a patient surgical or therapeutic or pediatric. First, it is inspection. With inspection, we can see, first what we can see, it is special posture of the patient. We call it Antigenic position or Antigenic posture, or another name, we call it forced position. It is a special position which patient use to reduce pain. Take a look. Usually, patients have a lateral bending to the side opposite to the side of compression. So if the patient have a compression of the right spinal nerve, he'll have bending to the left side. So patient try to increase the space for the nerve. If patient will be in lying position, what today we had a class and discussed that pathology with my students, and some of them seeing that pain or some symptoms which we can see that during the inspection will be changed depending from the position. It's not like that. It doesn't matter what is the position of the patient, is it standing or lying position or sitting position, principle still the same. Take a look. When the patient stay in the bed, he will use absolutely the same principle. Take a look at the lady, take a look to the lady. She tried to overstretch the right side. That means that the compression probably is on the right side. At the same time, left side become no, we can't say compressed. Thus, distance between the left shoulder joint and pelvic reduced. If the patient staying in the prone position, absolutely the same principle. Left leg is flexed and the right is straight. So patient try to reduce muscle tension, and flexion of the leg usually lead to some relief. And we can use that information. I will show you later how. Right here, LASEC symptom. So how we check it? You just put your patient in front of you into the supine position and ask him or her very slowly elevate straight leg. Usually, patient can elevate the leg on the healthy side in full volume. But on the affected side, as soon as the angle in between the leg and bed become around 30-35 degrees, patients start to feel very intensive pain. The location of the pain can be on the posterior surface of the leg, or usually it's the thigh area, or pain can be located at the area of the lumbar part of spine. In that case, LASEC symptom is positive. When the patient start to feel pain, you can check Degenerative symptom. You just take the leg of the patient and flex it in the knee. As soon as you will flex the knee, the pain will disappear or become not so intensive. This means that the Degenerative symptom is positive as well. So both Degenerative and LASEC symptom are positive in case of degenerative disc disease. Next step, it is sensation. You should check the sensation disturbances. You should check the presence of some neurological disturbances. For that reason, we will use dermatomes. As you remember, each spinal nerve innervate some special part of the skin, and the name of that part is dermatome. You should check three types of the superficial sensation. That's a tactile, temperature, and pain sensation. How to do it? I hope you remember. For pain sensation, you should use. We usually use needle. For tactile sensation, we usually use some brushes or cotton material, and for temperature we can use ice, or you can use metal part of the instrument. You just if it's a pain sensation, you just prick the skin, symmetrical parts of the points of the skin on the left and right side, and usually if it's a hernia, if your patient have a prolonged pain syndrome, usually they have, together with the pain, they have some hypostasia. So patient will tell you that my right toe on the foot is not so good as the left one. I can't feel that prick properly. And it is very useful because when you check different dermatomes, you can find out what is the location of the hernia. and have your patient neurological disturbances. Next, what you should do, you should check the muscle power. I told to my students that I prefer to use ASIA scale. What right here on the slide you can see. You can see how that scale looks like. You can see that we have a motor part and sensory part. For sensory, you just cover the area where your patient have some sensory disturbances. For motor part, you use different gradations. So we have muscle weakness. We can split the muscle weakness for few grades. Grade 1, it is very weak muscle power, which can be negated by the gravity forces. Grade 2, it is minor, very weak movement, which you can feel with your hand. You just put your hand on the foot and ask your patient to press on your hand with his foot. And you do it on the symmetrical parts as well. So with your hand, you can feel how strong is the movement of the patient, and you can compare it with the healthy side. So grade 2, it is very weak movement. Grade 3, moderate weakness. Grade 4, it is almost normal, but a little bit weaker compared to the healthy side. And grade 5, it is absolutely symmetrical, full power movement on the both sides. After the motor dysfunction, you should check, of course, reflexes, and it will help you to understand two things. First of all, location, because if you will find out that, for example, your patient have a weakness of the Achilles tendon reflex, that means that, location of the hernia somewhere in between L5 S1 or L4 L5 vertebrae. If it will be knee joint reflex weakness, you will understand that probably the hernia located somewhere above. And weakness or absence of the reflexes, but absence usually for Achilles tendon. And if the reflex is absent, probably your patient have some not only intervertebral disc hernia, let's say, it can be some peripheral diseases of the nervous system or diabetes, but hernia itself can't lead to total areflexia if you talk about the Achilles or knee joint reflexes. And as soon as you finish with the clinical examination, I forget to tell you about palpation. Of course, after the inspection, next step is palpation, and during the palpation, you can find muscle spasm. You will find out the paravertebral muscles become stay in hypertone condition. It is normal protective mechanism because any movement in between the affected vertebrae will increase pain. Okay, so as soon as you finish with the clinical examination, next step is instrumental methods. And right here on that slide, you can see the X-ray of the patient with degenerative disease. During the X-ray examination, you can see three classic symptoms. First one, it is narrowing of the disc space. Take a look, distance in between those two vertebrae and distance between those two. You can see that almost double reduced high for that intervertebral disc. So it is the first symptom. Second one, it is so-called subchondral sclerosis or end plates sclerosis. That means that the density of the bone right here and right here will be increased. So what is the reason why it's happened? It's happened because of overloading. As I said before, intervertebral disc, it is shock absorber. If the shock absorber becomes damaged or degenerated, in our case, that means that the loading will be displaced somewhere. In our case, it will be displaced directly to the vertebral body. And if it will happen, body will try to protect itself. Bone, it is a live structure. So increased loading, that means that the bone should become more dense. That means that we should have higher concentration of the calcium, higher density to keep that loading. So that overloading will lead to the subchondral sclerosis or sclerosis of the end plates of the vertebrae. And the third symptom, it is osteophytes formation. So as you can see here, those spikes which we usually have at the corners of the vertebral bodies, it is a result of overloading as well. Once again, when the discs start to absorb loading, overloading of the body will lead to some protective mechanism activations. One of the mechanisms is sclerosis, and the second mechanism, increasing of the area. The bigger area, that means that the less pressure on the surface. So body will try to increase its surface. How to do it? This way, formation of the osteophytes. So osteophytes formation, it is not a result of some salt metabolism disturbances. Osteophytes formation, it is the result of mechanical overloading of the vertebral bodies. Next method, which we almost not use at present time, we use it, let's say, we use it very, very rare. It is discography. As you can see here, for normal X-ray examination, intervertebral disc is absolutely invisible. But if you will inject some contrast solution, for example, it can be indigo carmine, the disc will become visible. But for that reason, we should put needle inside the disc. We can use different approaches, but what this one, the central one, is very, very dangerous as for me. So I prefer to use a lateral transforaminal approach from the lateral side, and after that you can inject the contrast solution. Why we not use it? Because at present time we have MRI. During MRI examination, the disc tissue will become visible without any needles, without any contrast solution. So when we use it, when we still use discography, I will tell you a little bit later. Myelographic examination, same principle, but we will inject contrast solution not into the disc. We will inject it inside the cerebral spinal fluid under the dura mater. And after that, that cerebral spinal fluid will become visible, and we will see so-called sandwich symptom. You can see accumulation of the cerebral spinal fluid above compression, above the level of compression, and below the level of compression. So that means that probably On that level, in between those two vertebrae, right here, we have intervertebral disc hernia. Not very common method at present time. Why? Absolutely right, because we have MRI. Take a look. For MRI, normal MRI examination, we will see intervertebral discs, first one, second one, and last one. That is the sacrum, S1 vertebra. This one is L5. This one is L3. Take a look. Normal disc color. If the disc is not degenerated, the color is white. If you have disc degeneration, the color become black. Why it's like that? Because white color, this means that we have a high fluid or liquid accumulation. Less concentration of the water, less concentration of the liquid, the color will be changed to black. So in our case, we have a black disc, we have a degenerated disc in between L5 and S1 vertebrae. That white color line, it is cauda equina, cerebrospinal fluid with the roots inside. In normal condition, intervertebral disc shouldn't came out behind posterior surface of the vertebral body. But take a look here. In our case, the L5 disc came out. We have a huge hernia which came out behind the posterior surfaces of the vertebral bodies, and as a result we have a compression of the nerve on the posterior side. That is a CT scan imaging, not very clear. If you're not experienced, it is very difficult to understand where is the cauda equina inside the canal, where is the hernia, where is the spinal nerves. That's why we have color, absolutely same color picture. So that is a facet joint right here. It is a cartilage, articulating surface, and another articulating surface. And same picture on opposite side. So one, first and second facet joints. That blue color, central blue color tissue, it is nucleus pulposus, and that peripheral part, it is the annulus fibrosus. As you can see, we have a rupture of the annulus fibrosus, and nucleus pulposus came inside the canal. But take a look, the central part, cauda equina itself, have enough space to step back, because the size of the canal, actually the biggest size of the canal, biggest diameter of the canal, we have right here at the central part. And the canal shape, the canal form is quite similar as, no, let's say triangular form. So the biggest distance we have at the central part. So cauda equina can step back. Our spinal nerves located in the corners of the canal, in between the facet joint on the back and intervertebral disc on the front. So that hernia compress the right spinal nerve. So that patient probably will have right side sciatica. Treatment. As usual, we have two options. The first one, it is a conservative treatment, when you will prescribe medicine which reduce the symptoms of the disease. At present time, we doesn't have pathogenetic treatment for osteochondrosis, for degenerative disc disease. At present time, we have only symptomatic treatment. What we should do, what are the steps of the conservative treatment? Of course, decrease physical loading. Use the special bandages or special fixator, which will reduce the loading during everyday activity. You can prescribe traction, massage, medical gymnastic, reflexotherapy, physiotherapy. If we'll talk about the medicine, of course, the first group, most commonly used group, it is non-steroid anti-inflammatory drugs. So main idea why you prescribe NSAID, of course, it is pain relief. Examples, the best way if you will use COX-2 selective non-steroid anti-inflammatory drugs like meloxicam or coxibes, for example. Second group, it is mere relaxant. If you have muscle spasm itself, it is quite a serious problem for us and for our patients, because prolonged muscle spasm will lead to the pain development as well, together with the inflammation which we have inside the canal. So we should reduce that muscle spasm, and for that reason we can use central myorelaxant. For example, tizanidine or midacal. Vitamin B1, B6, B12 complexes usually which will improve nutrition of the neurons. So we will try to save spinal nerve. We will try to restore the normal function of the spinal nerve. Glucocorticosteroids. Glucocorticosteroids, it is quite serious weapon in our hands, and with the proper using of the glucocorticosteroids, we can achieve really very, very good results. The best way, if you will use glucocorticosteroids as a blockade, not intramuscular, not intravenous injection, but if you will put that medicine exactly inside the vertebral canal. Right here on the right side, that is a point, you can see where we have so-called hiatus sacralis. If you remember anatomy, at the central part of the sacrum we have a hole. Through that hole you can reach vertebral canal. So if you will use quite long needle, you can put it right here inside this, and through the sacrum you will put it inside the canal. If you inject glucocorticosteroids inside the canal, we will receive from one side high concentration of the substance inside at the area where we have pathological process, where we have inflammation, where we have compression of the nerve. From another side, we will have minimal concentration of the medicine in the bloodstream. Of course, some part of the glucocorticosteroid will reach the blood, circulate in the blood, in all our body, in the body of the patient, and lead to some side effects. But anyway, concentration of the substance will be a few times less compared to intramuscular or intravenous injection. So blockades, that is the best option, but it is invasive procedure. You should have some skills to perform it. Other points, that point we use for sciatic nerve blockade. As for me, very rare procedure. Those 2 points on the left side, this one we use for facet joint blockade. Usually it is around 1 cm laterally from the tip of the spinous process of your patient. You just put the needle till the bone, and usually that bone surface, it is area of the facet joint. And finally, this one, it is the area how you can reach the nerve which is came out from the intervertebral foramen and go to the soft tissue to provide innervation to our extremities. Not very common approach as well. If you will talk about the transforaminal injection, it is right here. Usually it is 14-16 cm laterally from the spinous process, somewhere here, but it is very dangerous procedure. You should use C-arm, you should use X-ray navigation. Other way, you can damage kidneys or aorta, so you can damage quite important vital organs. Okay, If you use, let's finish with the conservative treatment. So glucocorticosteroids injection, then peripheral vasodilatators. If you will see that your patient have some ischemia, nerve ischemia symptoms. So if you will see that your patient have numbness, some motor dysfunction, then you should use medicine which will improve blood circulation, and usually it is Trimtal or pentoxifylline intravenous injection. So that medicine lead to the peripheral vasodilatation, but you should be very careful because the side effect in case of that treatment is overloading of the heart. So if it's elderly patient, you should be very careful with that group. And finally, physiotherapy. Main idea of the physiotherapy: reduce pain, reduce inflammation. It can be phonophoresis with glucocorticosteroids, with hydrocortisone, for example. It can be electrophoresis with lidocaine solution to reduce pain. It can be magnetic field, but in all cases, as you can see, it is anti-inflammatory procedures. If your conservative treatment is not effective, so if you will see that the pain is not disappeared, if you will see that neurological symptoms not reduced, or opposite, you will see progression of the neurological signs, in that case you should use surgery. You should perform decompression of the nerve. You should perform disc hernia resection. We have quite many methods, but today I will try to show you most commonly used techniques, no except probably microsurgical technique. If we will have time, we will discuss it during the classes. I want to start from endoscopic procedure. It is for endoscopic procedures, we have quite many approaches. We have posterior approach, we have lateral approach, we have extremely lateral approach. So in that video, you will see lateral approach, transforaminal approach for intervertebral hernia resection. Oh, sorry. Oh, it is started. As you can see, for that procedure, we will need CR. That is an X-ray machine, which is located in the operating theater. It is absolutely necessary for navigation. So first thing which we will do, we will find out where is the location of our hernia. We will perform some measurement. For that reason, we will put some metal instrument on the patient's body and make two-plan X-ray examination, lateral and AP. So it will show us where is the level of our hernia. So that line, the blue color line, it is a line along the spinous processes. Let's say it is a central line. It is iliac crest. And right now, doctor performed measurement. He tried to find out where is the level of surgical approach. For that reason, you can put the metal instrument, any metal instrument, and like this, for example, and make the X-ray examination in two plans, as I said before, AP and lateral. So at that point, it is a point where we have hernia of the disc. After that, local anesthesia, and right after that we will take a long needle. The needle is around 16 cm and put it into the transverse foramen. When you put, it looks quite simple. So the doctor on that video, the doctor put the needle from the first try, but in real life it is not so simple to put the needle exactly at the point where it should be. So usually you spend some time to find out where is it to find out that the intervertebral foramen. After that, you put indigo carmine, that blue color liquid. It is a contrast solution. You put it into the intervertebral disc, and after that, it's become visible. So that is an example when we use discography at present time. Then you take out the needle and left only thin wire inside the disc. After that, incision, very small incision, I don't know, around few millimeters, 3-4 millimeters. And after that, you use special tubes, dilatating tubes. You start from the minimal diameter, then put the bigger, 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 bigger. So the main idea is that each tube increase the hole, split the muscles, split the soft tissue, and make that whole surgical approach bigger. And finally, last diameter tube. It is a reamer. So a doctor already put the last diameter tube, but after that he decided to increase the size of the intervertebral foramen. Quite dangerous procedure, should be very careful. So reaming of the facet joint, increasing of the intervertebral foramen. Take a look. Well, that is the intervertebral foramen. It is a spinal nerve which came out through that foramen. And when you perform reaming, you should be very careful. You should be always at the distal part of foramen. If you will go upward, you have a risk to damage the spinal nerve. So that is a reaming procedure. You see, very close to the nerve. Right now, the size of the intervertebral foramen increased. And after that, we put reaming again. Okay. And after that, we put endoscope inside. So what is the main difference of the, we call it foraminoscope, да? What is the difference of that endoscope compared to the endoscope which the general surgeons use, for example? For that endoscope, we have all necessary working canals in one. We have light source, we have irrigation, we have working canal in one tube. For general surgeons, they have light source, camera, and irrigation in one tube. Working instrument they put from another different approaches from other sites. In our case, we can't do it. In our case, we have one hole, and through that one hole, we should put all together, instrument, light, and everything what we need. So all in one. Oh, perfect. Take a look. Light source, irrigation, working canal, the biggest hole, it is a working canal. Through that working canal, you will put necessary instrument inside. That is the instrument, and you just cut the hernia piece by piece. So the size of the fragments usually is very small, few millimeters, step by step. So you just take out the hernia. Very good. Last fragment. You see, and the compression to the nerve is reduced. And then you can use ultrasound. It is not coagulator actually. It is device which will help you to we call it ablator. You perform ablation of the intervertebral disc. You will close the gate for future hernia development. That's it. That's it. Now, the doctor will take out the instrument, patient will return to the ward, and next day patient can left the hospital. So it is 1 day procedure with a minimal period of staying in hospital and very fast rehabilitation. And next technique which I want to show you, it is a technique which is more traumatic, and we use the technique in case of instability of the spine. If we need to not only to remove the hernia, if we need to fix the vertebrae together. So take a look, the size of incision here, usually it's around 12-14 cm, so quite serious incision. Then doctor splits the muscles from the spinous processes like this, and we can see arcs of the vertebra, spinous process and arc of the vertebra. It is a facet joint, spinal cord, but you can't see this cauda equina from that approach, of course, because we have a yellow ligament here, which is cover that cauda equina. But in video, it is more simple. It is L4, it is L5 vertebra. This one is S1. So we have a herniation between L5 and L5S1. So what the doctor will do next, he will cut the arc, cut the lamina. Take a look, take a special instrument, cut the laminas and perform laminectomy on 2 levels. Quite traumatic procedure. Right after that, with a special reamer, doctor will remove the lateral part of the lamina, lateral part of the arc, and now it is time to take out the hernia, probably. Right, so move the spinal nerve and take out the hernia, which compress that nerve. After that, we will use special cage, special implant, which we will put in between the vertebral bodies at the place of intervertebral disc. And final step, it is transpedicular screws fixation. So we'll take the screws and put those screws inside the vertebral bodies through the pedicles of the vertebrae. And final step, we will fix those screws with the titanium or stainless steel rods. So in result, we will receive like a frame which will hold all vertebrae together and prevent any movement. So it is a combination of the decompression and stabilization. That's it, what I want to tell you today. Do you have any questions, colleagues? I can't see any questions during the lecture, so no questions. Okay. Then this is it. Goodbye and good luck.